Good evening. Thanks, everyone, for coming, and welcome to this seminar, Healthcare Under Conflict in Sudan. My name is Richard Baltrop. I'm a visiting senior fellow at the LSE Middle East Centre. We've got 4 speakers for the event this evening. We'll be giving 7 to 10 minutes for each speaker. And we'll try and keep time quite punctual so that there's plenty of time for discussion with those of you who are here in person and those online. A brief, shortest introduction to the topic. Why this topic? Of course, the reason is that Sudan has been faced with a terrible war since April 2023, the war that began between the Sudan Armed Forces and the Rapid Support Forces. That war, the costs of it, the human costs, have been staggering. As of October, November, figures from the United Nations, around 8.2 million internally displaced within the country, and a further 3 million Sudanese and South Sudanese, displaced as refugees abroad to neighbouring countries and further afield. So that's more than 11 million people, something like a quarter of Sudan's population who have been displaced. Humanitarian aid needs, or humanitarian needs, have been enormous. Our 4 speakers, I'll introduce briefly now. Our first speaker will be Ibrahim Bani, who is an Associate Professor Adjunct at the Yale School of Public Health. Professor Bani is a public health physician by training with over 20 years of experience in international public health. His teaching experience is extensive, including faculty appointments as an assistant and associate professor in community health at King Saud University in Saudi Arabia, and as a lecturer at Jazeera Medical School in Sudan, which is internationally known as an innovative community-based training center. And during his tenure at those academic institutions, he's participated in many national training programs sponsored by organizations such as the World Health Organization, USAID, and national governments such as from Saudi Arabia, Sudan, and Iraq. His own educational background began at Khartoum University in medicine, and then later in London, and a doctorate in the UK. Ibrahim is joining us online from Washington, I believe, Ibrahim.
Yeah.
Ibrahim, we'll begin with you in 2 minutes. I'll just introduce the other speakers. Our second speaker will be Nahid Toubia, who is online. She is a researcher and practitioner and activist in the field of sexual and reproductive health and rights. She started as the first woman surgeon in Sudan and then moved to work internationally, first with the Population Council in New York, and then as the founder of an organization, RINBO, for health and rights for African women. She has served as a technical advisor to the WHO and several UN agencies, national governments, the World Bank, and as an adjunct professor at Columbia School of Public Health, and a visiting lecturer at Harvard, and also a visiting lecturer at the London School of Hygiene and Tropical Medicine. I'm going to pause the introductions there, and I'll introduce our 2 speakers in person when we come to them in time. Our 2 speakers on either side of me are Eva Khair and Majdi Osman. But pausing there, let us move to the first presentation. Ibrahim, would you like to proceed?
Thank you, Richard, for introducing me. First, I would like to say good morning, good afternoon, and good evening to those who join us for this conversation in this session. I am going to highlight on the issues of the challenges facing healthcare in conflict-sensitive area with a focus in Sudan. And the agenda for this conversation includes this agenda talking about the health system in the pre-war affected by instability in political and social and economic life, rapid turnover of senior level staff, COVID pandemic, outbreaks, and freezing of public projects due to instability. Also, the impact of war includes the current impact includes displacement, as Richard just mentioned. One of the largest displacements in the world, and humanitarian aid needs for 26 million, almost more than half the population. There is partial or complete destruction of institutions, and also the medical supply effect destruction and looting of cold chains, and more than 100 ambulances or 400 vehicles has been looted and destroyed. Also, the impact include more than 50 health personnel were attacked and killed. A recent one over this weekend, one of the doctors had been under attack. 50% of Sudan is very hard to reach. There is damage of the health information system, fatigability of health services at the states with high displacement, especially the River Nile, Northern and Red Sea state. Loss of 70% of specialized services for cancer and for renal dialysis. Also, there are accumulated complications, especially people with chronic disease like renal dialysis, brain drain, and the exodus of most of the healthcare providers outside the country. And why I consider Sudan is a sensitive conflict, because there is decades of civil war between North and South culminating in these vendors of 2002, 2011, ongoing conflicts in some regions of Sudan. The recent conflict started between the Sudanese armed forces and the rapid forces, and the government instability since the overthrow of the President Omar al-Bashir in the recent revolution. I am going to shed light on the medical neutrality concept, which refers to the principle of non-interference of medical service during conflict and other humanitarian crises, and mainly it deals with violations when it occurs, especially violations against civilians, medical facilities, and medical personnel. What are the main challenges in medical neutrality include numerous attacks on hospitals, clinics, hindering access to medical care. There is shortage of medical supplies, and also healthcare workers facing a lot of problems. Violations include attacks on hospitals, patients, medical personnel, medical transport, and medical facilities. Violations also had led to decrease in functions of healthcare facilities and the rise of preventable diseases with the spread of some diseases. Human rights violations in recent Sudan war include attacks on medical facilities, bombing of hospitals, especially in Khartoum and Durman, leading to casualties, killing of medical personnel, and there's some reports about this. These are the operations during the war, health cluster, and the coordination of the Federal Minister of Health and the World Health Organization, in which there is 19 international NGOs and 7 national NGOs working in different parts of the country. My takeaway for this conversation of today is understanding the concept of medical neutrality, recognize the importance of protecting medical personnel and patients and facilities in conflict zones, and also understanding the sensitivity of these areas and stability and the challenges. Today, we also will talk about the awareness. We need to raise the awareness about the common challenges and violations in facing the upholding of medical neutrality. Also, the takeaways include advocate to or accessing to conflict areas, especially for humanitarian actions, negotiation of ceasefire or humanitarian corridors to ensure the safe delivery of medical supplies and personnel, enforce international laws for protecting facilities and personnel, establish mental health programs to address trauma, investigate how communities cope with these low health services. The global community has a shared responsibility to help in upholding the medical neutrality and support affecting regions, especially in Sudan. There is a video see it later. Even wars have limits. This is a statement related to the international humanitarian law. War should be fought with dignity and saving lives. Thank you.
Thanks very much, Ibrahim. That was a very good presentation. Sorry we couldn't project the video at the end. What we'll do is we'll move on to Nahid next, and we'll do the questions when all four have spoken after. Thank you. Nahid, would you like to proceed?
Yes, thank you, Richard, and welcome everybody who are in person in the room or online. Thank you, the London School of Economics, for shedding light on Sudan, which is not neglected, but ignored, I would say, the conflict. It gets reported, but not much is happening. Anyway, let me introduce myself quickly. Not that Richard hasn't done a very good job. He's done a wonderful job. I just wanted to say that until 15th of April, 2023, the day the war started, I was the founder director of the Institute for Reproductive Health and Rights in Khartoum, Sudan. That institute we started in 2016, and what it did is brought the issues of reproductive health and rights, reproductive and sexual health and rights to the forefront of health systems in Sudan. We trained a lot of doctors, junior doctors, medical students, OB/GYN specialists, psychologists, and also civil society organizations on what it means. What do we mean by sexual reproductive health and rights? Until that day, our institute was taken over the second day of the war, and it's on Street 5 in Amarat in Khartoum, and to this day we have not been able to access the institute. So it's still taken by the Rapid Support Forces. They are actually living in it. Before I go into the details of the issues that I'd like to highlight, I also want to mention that in March 2023, just the month before the war started, I was invited to speak at an international humanitarian conference in Belgium. And to my surprise, the panel that was going to speak about reproductive health and rights, which affects everybody, but affects, of course, women much, much, much more, was not put as very of that much importance or significance in the conference, and not even many people wanted to attend the panel, and those who attended were mostly women. What I'm trying to say is what I'm going to highlight are the issues that are highly neglected when we actually talk about humanitarian support for affected populations. Women are affected more because women have the wonderful function of carrying pregnancy, carrying babies and delivering babies, which is one of the most wonderful things, which is producing human beings. Yet, unfortunately, that puts them and their bodies into extreme vulnerability that gets ignored because it's not affecting the rest of the population or men, basically. Okay, so what do we mean by issues of reproductive health within the context of conflict? I'm not going to talk within the bigger issues of SRHR, but within conflict, I want to start with the simplest. Yes, we can talk about hospitals and diseases, but there are lots of health, as we all know, we're all health practitioners. Health doesn't start in the hospital. Let's start with the young women who are menstruating every month. Can you imagine somebody on the run who actually has no water to clean herself, has no menstrual products, what we call menstrual poverty, which affects girls even without conflict? Can you imagine the girls who are actually bleeding every month and has no access to clean themselves? They get infected. They could even get infertility if they get infected. These are not even mentioned. And these girls also have the whole, social shame of showing that they're menstruating. When packages for humanitarian aid does not have menstrual hygiene issues, or products, not even thought about. Let's move forward and say, okay, women are married, they get pregnant. I'm not even talking about the non-married ones. I'm just talking about in families, women are on the run. Somehow, even under the most dire conditions, somehow women get pregnant. We know how they get pregnant. Have to have sex to get pregnant. Somehow it happens. I don't know how it happens under these conditions, but they do. We haven't researched how it happens or why. We don't know what conditions they live even within their families or within their men that makes them. If we talk about research, I think we need to know more about that. How do these women cope under these conditions? So they get pregnant because there are also no contraception. Again, packages of relief do not have contraception. What I would propose is that there ought to be a whole range of contraceptions, part of the relief efforts, but particularly long-acting contraceptions like implants. Not to be forced on women, but if they want them, they get them because they need to protect it. Can you imagine? You can hardly eat. You are weak. You don't have enough food. You're on the run. Then you get pregnant, and you can't even stop it because, as I said, socially pressures, whatever, still happens, and people get. We always say, "Oh, we're not getting any maternal care." But we don't think, how did they get pregnant to start with under these conditions? Anyway, next thing is, of course, pregnancy itself. Pregnancy is a normal condition that women have, but pregnancy is also a huge vulnerability and risk for women. They can have miscarriages. Can you imagine if you're on the run and you get a miscarriage? She will probably bleed to death with no services, and nobody mentioned it. They probably are not even counted when they count the deaths. We only count the deaths who are killed by bullets, but not the deaths who are dying of bleeding. There is, of course, very little antenatal care under these conditions. And obviously, labor is probably going in the condition that Sudan is in now, is probably going back to prehistoric times where women have to deliver on their own with no care, with no facilities. Again, that carries huge risks and death, but that doesn't get even counted. So I'm just trying to mention the kinds of issues that women suffer every day that are not included in humanitarian aid, and also not included even when we count who's affected. So I could go on for a long time mentioning a lot, but I think I hope you got the message of what I'm trying to say. Now, of course, beyond this so-called normal living where women have to deal with their own bodies, there is the bigger issue that happened in this war that has not happened in Sudan on this scale ever before. Even when there was a war between the North and the South, that rape was not used to the point that is being used right now. Men use their body as a weapon, and the rapid support forces have been raping women in their hundreds. Again, there is very little, there is reports on rape, but there is not much responses to what you do about it. There is a lot you can do with rape. To start with, again, in packages, relief packages, you can even have things like day after pills so that women don't have to get pregnant when they get raped. But they're not there in the packages. Psychological support for women who are raped. A woman who's raped is marked forever. She is hurt forever, let alone complicated by the conditions of war in a country where honor and exposure to sexual violence is not only is she affected by the violence, but affected by the shame, the social shame that comes with it. Now, of course, there are actually ways to support women even under these very low level resources. But again, they're not part of what is packaged in the humanitarian relief. Finally, I just want to say that one of the worst things that can happen is when a woman gets raped and then she gets pregnant from her rapist. If you all remember in Bosnia, that was a huge issue at the time of that war. And actually, women's organization worked a lot to find ways to help these women. We need to learn from these histories, and we need to learn how to support these women, particularly those who then have children who are the child of the rapist, and what that does to social structures and how she's considered and thought about within her community, and why they actually could become pariahs. So I'm going to not keep mentioning even more horrors, but all I want to say actually, while all these things are happening, there are solutions. But the first part of the solution is to be aware of the issues. That's why I chose today to talk about them. It doesn't take very much to actually find ways to help the girls and the women. But the solution have to start, and here is the issue of research. We have to start by asking the women what is best for them. We cannot impose things on them. How can girls best be supported for their menstrual hygiene? How can women best be supported in managing not to get pregnant? How do we best support them to deliver safely? And how do we help them? Well, if we can avoid having the sexual violence, that would even be better, but that's not always possible under the conditions we have with what the RSF is doing. But there are ways to support women who have been sexually violated and raped. I'm going to stop here and, with any answers for any questions. Thank you.
Thank you very much, Nahid. That was a very powerful presentation, and we will move now to our two in-person speakers, and Nahid has said we'll do questions all together at the end of the 4 presentations. So our third speaker is going to be Majdi Osman, who is a doctor and scientist at the University of Cambridge and the Wellcome Sanger Institute. Originally from Sudan, Majdi founded Nubia Health, a health organization in Wadi Halfa in northern Sudan, which has been building community health or establishing community health worker programs and primary healthcare centers in northern state, the largest or a large state in the far north of Sudan. Majdi is visiting faculty at the Harvard Medical School and the Harvard School of Public Health, where he completed his training and is a trustee of the African Research Excellence Fund, supporting early career scientists, early career African scientists, to be exact. Majdi, please correct me if I've got anything wrong there, and over to you, Majdi. 10 minutes, up to 10 minutes, your presentation. Thank you.
Thank you, Richard, and thank you all for joining us this evening when you could be doing many other things. And I think, Dr. Ibrahim and Dr. Nahid really, I think, portrayed the sort of the impact of this war at the national level for the health system in Sudan. And what I'd like to do for the next few minutes is to present the experience of healthcare workers in a very specific part of Sudan, in Wadi Halfa, which is right in the far north of the country, between just next to the Egypt-Sudan border. and to potentially sort of present some of the challenges and the way that healthcare workers have been overcoming those through the last year or so. And so Wadi Halfa is where we're originally from, our family. Before the war started, we were working on setting up community health worker programs and primary healthcare centers as part of this project, an organization that we founded called Nubia Health. And before the war, Wadi Halfa was a pretty quiet, sedate place. A border town, but very little traffic, very few people crossing the border, and quite peaceful, a population of just over 100,000 dotted in the center, and then a few other villages along the river. What I'd like to present today is sort of the experience that we've had as a team. These are the people. So I think, we talk a lot about the statistics of the impact of the war on the health system in Sudan. But these are the individuals, parts of the Nubia Health team. We're 11 full-time people now who are there in Sudan, in Wadi Halfa right now. I think some of them are listening to this meeting today. And, what have they had to overcome in order to continue delivering healthcare to the communities that they've served, and the challenges that they faced. And before the war started, our focus was really on community health. Dr. Nahid said health starts at home. It doesn't start in hospitals. And that was actually the approach exactly that we've been taking, to bring healthcare to schools, to communities, to homes, providing education at Wadi Halfa Girls' School, for example, on the basics on nutrition and healthcare, and really trying to address the gap that there was in the Sudanese health system, which has historically been very centralized and very much focused on hospitals, when really what we wanted to do is try and address the gap in community-based healthcare. And this is Wadi Halfa Hospital before the conflict, and frankly, it was like this most of the time, very empty, very quiet. Levels of trust in healthcare in Sudan were very low, especially in the periphery areas. This is a healthcare center where they were often having to perform cesarean sections without access to water, without access to anesthetics, without access to cleaning equipment. And this hospital is just a few meters away from the River Nile. And so the breakdown in infrastructure and the lack of functioning health systems before the war is just something for us to consider, I think, because already going into this conflict, Sudan's health system was extremely fragile. And to take on the challenges of the war afterwards, I think you'll see sort of the pressures that it's brought onto the health system. And so April the 15th, the picture in Wadi Halfa changed dramatically. This is the Argin border, so not too far from Wadi Halfa, where hundreds of thousands of people were passing through. And for our team that were dealing day to day with going to schools and providing community-based healthcare, trying to sort of address some of the gaps in care before the war started, they were now faced with the challenges of hundreds of thousands of people arriving from Khartoum, and not just with the challenges of maternal and child health and infectious diseases, but hypertension, diabetes, kidney disease, cancer, and these really complicated medical conditions that people were often having to seek care for in the center of the country. And so this raised the first challenge of what this conflict meant for healthcare in Sudan. When the war started, we arranged to try and deliver some supplies from Egypt. And we were very lucky in the first few days of the war to be able to get in trucks of medicines and foods and basic supplies. But that border is pretty sealed now. And I think maybe Eva and others will speak to this later on, that transferring any aid and delivery of food, medicines, or anything across that border now has become really challenging, to the point where we aren't able to actually do that anymore. And all of our supplies have to come from Port Sudan, which, for anyone who knows the geography of Sudan, is at least a couple of days' journey in a very sort of risky environment. And so, I mentioned that the population of Wadi Halfa was pretty small, pretty low density, and we were faced, with the challenge of, hundreds of thousands of people arriving, and with that border being sealed, people unable to make that move into Egypt and actually having to settle in Wadi Halfa. And throughout the conflict, Wadi Halfa has been relatively peaceful. There hasn't been any sense of the conflict there. But the folks that were arriving were impacted not just by the infectious diseases that we all know about, but also some of the challenges that Dr. Nahid mentioned around the experience of gender-based violence and the trauma of having gone through that. And so, our team adapted, and I should mention, Dr. Khalil and all of the folks that are in Wadi Halfa at the moment are just brilliant. They are heroes, really. And they took the challenge to and noticed that there were high rates of TB arriving into Wadi Halfa. And so what they did is they set up a house-by-house screening program to look for people who were infected with TB or potentially infected, and developing isolation units and treatment protocols for those folks. And so that's Dr. Khalil on the left there, doing some public outreach on TV in the northern state. We set up a small unit for doing some detection and microbiology in one of the empty buildings that we were given by the Ministry of Health. And then in terms of actually getting people treated, this was an empty room in one part of Wadi Halfa Hospital, pretty derelict. You can see a broken bed and not really used. And so the team decided to get some paint, clean the room, put in an air conditioning system, air filtration, and some beds. And now that's a space where people are being started on treatment for tuberculosis today, and is the only active TB treatment unit in Wadi Halfa at the moment. So the other challenge that the team in Sudan faced were the floods. I think many of you will know about the impact of the floods in a few months ago, that not only brought destruction in terms of houses and homes and tents, but also brought along disease, so cholera and other waterborne diseases. And so the team had to, again, adapt to, not just tuberculosis, but how do you treat people with cholera actively in a situation where tens of thousands of people are being displaced. And so we set up, or I should say the team there set up mobile treatment units to go and find people who'd been displaced in the community and to provide them with basic care with oral rehydration supplement and addressing other healthcare needs that they might have had. And this is just sort of a few more photos of just highlighting that, we did this outreach program to find people with cholera, but you find people with, uncontrolled diabetes or uncontrolled hypertension. And so, you're not just, I think one of the things that sort of has kind of been a learning for me is that the divide between humanitarian crisis and ongoing healthcare needs is not black or white. And actually, as we think about health systems and restoring health systems, that it's not just a separation between the humanitarian and the health system sort of paradigms, which often is how funding is allocated as well to these types of crises. I'm mindful of time, so I'll sort of whiz through the last few photos, but this isn't just a photo of a little piece of paper that's a bit fuzzy. This is our certificate from the Humanitarian Aid Commission in Sudan. And the story behind this is hours and days of bureaucracy and patience and going to an office in Dungala and trying to knock on the door and find the right person who can sign a form. Bureaucracy hasn't stopped in Sudan, despite the war ongoing. There's still this need to make sure that you're following the rules. And the team in Sudan are going to be there after the war ends. And so I think an important point is that we may receive pressure from funders, for example, to move extremely quickly and to get things done as quickly as we can. But if we're not in step with the Ministry of Health, with the rules, that potentially puts the team in a challenging position as the war continues. And just the last few slides, I think the other piece is technology. This is a Starlink that we were able to get into the country with the blessing of the Humanitarian Aid Commission. And aside from watching the odd Netflix movie, this has sort of transformed the experience for the healthcare workers in Wadi Halfa as well. They have access to WhatsApp groups now. You can see this WhatsApp group, which is basically a message forum for people calling for medicine supplies, funding to be shared to families that are facing difficult health challenges, and also education. And so there's an amazing project set up by a doctor called Dr. Nada Fadul in America called Project Echo, where she connects doctors from Sudan to doctors outside of Sudan for training, for education, for solidarity and moral support as well. And so this is just another example of how technology is, I think, transforming the experience for many of the health workers in Sudan. And lastly, I think, Sudan has been completely neglected by the humanitarian international architecture that has been set up over the last few decades. There's no aid going in, relatively speaking, compared to other conflicts. There's very little coverage relative to other conflicts. And we can sit and wait for that aid to come through, or we can find other solutions for finding that support. And so one of the things that we've started to do now is to build south-to-south collaborations with other countries and other conflict settings and understand how they've overcome some of the challenges they've faced. So there's an organization called Muso Health. They're based in Mali. They have done a number of rigorous randomized controlled trials to show that their community health worker programs can reduce mortality and maternal child health more than perhaps any other kind of transformation that you can do to a health system. And so one of our team members from Wadi Halfa is going to Mali to see how they do community health worker programming early next year and taking that back to Sudan. And they'll be taking some Ministry of Health people along with them as well to potentially disseminate that to the rest of the country. So yeah, other organizations that are doing amazing work are up here. SAPA, I'm sure many of you know about the Sudan American Physician Association, ECHO, I mentioned, the mutual aid groups and emergency response rooms. Yeah, please, I'm happy to share these slides after if you'd like. And just to finish up, I think these are the people who are really driving the response to the health needs of the community in Sudan. When we talk about numbers, when we talk about the money, let's just remember that these are the actual people who are doing the work on the ground. And in all of the sort of dire news that we've had over the last few months, I should say, to me, this is a sort of silver lining, and I think points us to the future of how Sudan can recover after the conflict as well. So yeah, thank you very much. And sorry, Richard, I went over.
No, thank you very much, Mejdi. That was perfect. Very good timing, and great to have such a visual accompaniment to your presentation. Eva, as our fourth speaker, Eva is a British-Sudanese medical doctor and a global and humanitarian health consultant, and also has been and is a political and parliamentary advisor on Sudan. She's founded and directed one Sudan initiative called the Sudan Transnational Consortium, a network of Sudanese professionals aiming to support peace building and collaborating in order to draw international attention to conflict and humanitarian concerns that affect Sudanese populations in Sudan and in the near abroad and in the diaspora. Eva, please clarify, correct anything in my introduction of you, and over to you for up to 10 minutes, please.
Thank you. Thank you. I hope everyone can hear me. And thank you very much, Richard, and esteemed colleagues. I think you've painted a very vivid picture of what's going on the ground. And one of the reasons that I was so keen and happy with this event is that it sort of took this gargantuan mantle of humanitarian and broke it down a little bit. I want to see more in education. I want to see more in livelihoods. I want to see more on cash. We just need to break down this humanitarian behemoth that we keep talking about. And health, of course, is one very important area, and one that I'm, of course, concerned with because of my line of work, but also because it is about life-saving in that very material, real way. It is not about mincing words. This is about a hemorrhaging population, a hemorrhaging country, and getting that bleeding to stop. And the hashtag Sudan is bleeding is really no joke. So, I did, and thank you for indulging me and putting me last, because what I really wanted was for my colleagues to paint the picture of what is going on so that I could come along and say, health is political. I don't need to talk about the statistics that everybody in this room knows. If you're here, you know the stats. If you're watching, you know the stats. My colleagues have drawn attention to some of the most pertinent in their areas. But at the end of the day, health is a political matter. It's even a political matter here with the political football that the NHS has increasingly become, but certainly in a conflict like Sudan, which is a man-made humanitarian disaster. It's not a flood, it's not an earthquake, it's not a volcano, it is a war, a man-made, very much man-made war. So when we have a study like the London School of Hygiene and Tropical Medicine paper, which came out 10 days ago roughly, that looks at sort of mortality in small part of the country, just in Khartoum, 61,000 deaths, and says that 40% of those are conflict-related, by gun, by murder, by death, by torture, whatever you want to call it. 60% are not directly because of a gun or some violence like that. And that is where this health stuff can start to address what the problem really is. So in a situation where we have no, let's say, deference to international law, let alone compliance with it, where we have no law, no order, and I'm talking civilian, there's no police, there's no courts, there's no judges, there's no basic rules of conduct, no gentleman's accord, there's just nothing, there's only the gun, there's only power versus the population. To me, it's quite obvious that when it comes to tackling the issue of healthcare and civilian infrastructure, which is life-saving, we are talking about a protection issue. And it is incredible to me how there are those who would play a political football with protection and talk about sovereignty here and there and other such fantastic words, when actually what we're talking about here is the sovereignty of women, their bodies not being attacked, not being raped, the sovereignty of children, the sovereignty of their futures, the sovereignty of those resources that belong to the people. Where is that sovereignty? From my perspective, healthcare is a protection issue. Why? When we have powers that be bombing hospitals, assaulting and killing medical staff in the course of their work. It's not even like you were in the wrong part of town, we shot you. No, literally walking into theater as a surgeon is performing a C-section and shooting. That is a protection issue. That is not just a woolly, comfortable humanitarian health issue. That is a direct protection issue. When it comes to things like vaccinations, that is it's the first line of defense. That is protection. Where are those programs now? They've all but frittered away. There are fantastic pictures all over social media of wonderful vaccination campaigns happening in Port Sudan. Whoop-de-doo. What about the rest of the country? And how many children is that anyway? You know, there are humanitarians and health dons and so on, health czars who visited the place and said, oh, look, there is something happening here, but there is massive, massive need. That's very, very choreographed. The pictures that the rest of us see on our phones every day, every morning, every night, do just tell a different story. So, vaccinations, sexual and gender-based violence, we've already had that. I don't need to go into it. But when we talk about STDs, sexually transmitted diseases, physical and mental health needs, unwanted pregnancies, unsafe abortions, suicides, that is a health issue. It's a protection issue. Frontline responders, including doctors, mutual aid groups, ERRs, and so on, being attacked, and again, not by accident, being targeted. As soon as you have one area that is won or lost in a territory, whichever force plants the flag decides that everybody who was providing a service in that area, because they were making things work and shaking hands with the enemy in order to get medicines in and to make life go, is now the enemy. You're a collaborator, so you get shot. So you risk, as a doctor, as a nurse, as a radiologist, radiographer, whatever you are, as a health practitioner or as any kind of, civilian defense force, that if you try to help your community, if you try to save lives, if that territory is lost to the current king, to the current winner, the next general will just shoot you. It is a protection issue. So beyond the health thing, we have poisoning of wells, we have hunger, we have starvation, we have asbestos, we have all those buildings reduced to rubble, the amount of pounds and thousands of pounds of asbestos in the air. From my point of view, war is a public health crisis. And I want everybody in this room and everybody you talk to come away with that notion that it is not separate to what we do as healthcare professionals. War is our problem. It is a public health problem. It is a global health problem, whichever way you slice it. And so when it comes to terrifying projections like 12 million may suffer from starvation in a sort of not the most modest analysis, but an analysis that by next June, 12 million could die of hunger, and any of us know that hunger and disease follow each other like night and day. What does that mean? If you don't die by sword, you die by hunger. If you don't die by hunger, you die by disease. And round we go. This is a protection matter. And so where people get a bit divisive about, is this protection, something that looks very scary, something that looks very, let's say, a show of force, that looks like boots on the ground and all that. Well, actually, protection has many rungs on the ladder before it ever gets there. Protection is telecommunications being restored in every state. And how is that important to healthcare? To get information out. You have a Starlink. That is how you can communicate with your teams. That is how you collect data on polio outbreaks, which have, happened since January. Cholera, dengue, malaria, all the old friends of Sudan. When you have new populations in new areas getting exposed to new diseases, how do they even deal with that? Displacement is a problem. And so you need telecoms so that doctors can work together, so they can share resources and information, so they can talk to the outside world. There is a deliberate reason why telecommunications are down. It is a tactic of this war. Sexual and gender-based violence is a tactic of this war. Hunger is a tactic of this war, and so on and so forth. These are not byproducts. These are strategies. These are policies, by any other name. And so when we come to consider what protection could look like, telecommunications, humanitarian assistance, cross-line, cross-border, all the old things, so that colleagues can use that border that they sit on up in North Sudan, so that people can get aid in, and not just through, let's say, Sudanese diaspora contributions and others around the country sending and borrowing money to each other, but actually getting the international funds that have been raised in Sudan's name into the country. The physical presence, the safe zones, the green zones, the agricultural assurances, all of that is part of the picture, absolutely. But in this very divisive atmosphere that we have right now, where saying things like protection of civilians becomes somehow against the Sudanese sovereignty, against the Sudanese state, and somehow against the Sudanese people. Well, who are the civilians we're talking about protecting? We're talking about protecting Sudanese civilians. And that's where I think we as health professionals, we as health people, need to take a bolder step and not be afraid to get political. I'll leave it there.
Thank you very much, Eva. Could we have a round of applause for everyone? Thank you. Thank you. We have 15 minutes, possibly a little bit of extra time, to take questions. The gentleman at the back, please, if you'd like to ask your question.
I have organized 2 international conferences. The first one in 2005 at the Imperial College. Dr. Nahid Toubi was one of the speakers in that conference. It's about the health service, better health services for South Sudan. The second one is in 2010, held at the South for better health services in Darfur, both after conflicts. The recommendation of these 2 international conferences were published in the BMJ, and any interested individual can have a look at them. The difference this time is the continuous war which is going on now, and I find all the recommendations mentioned by the speakers were excellent, but the implementation is going to be very difficult without the stoppage of the war. Even what Dr. Bani is doing, that excellent work in Wadi Halfa, if the war went to there or spread to the north, the whole setup that you organized will be destroyed. Thank you very much.
The lady to the right here, please use your microphone and introduce yourself if you like.
Hello. I actually escaped the war and just came to England about 7 months ago. I was in Argene, escaping, and I want to mention how 7 days straight we had no water or food. 7 days, some people started eating sand. It was very, horrible. So there were aids, like you say, that were coming in, but they don't actually come inside. So we see the borders, we see Argene, all the trucks coming through, but we don't get any of that stuff. I don't know why, but there were a lot of questions about where these things go, because they were arriving, but no one was getting any of them, not the kids, not us, not the pregnant ladies, not the old men, no one. So I think it's important to, like Mr. Wright there said, to apply those things, to execute, it would take so much more strategy than theories, I would say. It'd have to be a lot of understanding when these things reach ground, what happens then. Because I think we have laws that can be perceived from outside, but once you're inside the zone, there is a lot of propaganda. And I think it's important to realize how we can create safe journeys for these, stocks to reach people. because it's still happening. That was something I dealt with 7 months ago. I know it's still happening till today. So yeah, thank you.
Thank you. And I'll take 2 more questions. Gentleman there with your hand up, please.
Hello everyone, my name is Oscar. I have a human rights rather than a humanitarian background. On that note, to anyone on the panel, I'm really curious as to, because we know that a lot of foreign backers are involved in this war, so the UAE in relation to the RSF, the Saudi Arabia, and some other forces in relation to the actual government. So have you seen any sort of intervention from a foreign state kind of move the needle in terms of humanitarian access? Any intervention from a state, or if a state gets called out in a scandal or something, that kind of lets at least temporarily something in? I'm just thinking of those influencing opportunities and actions that we could do somewhere here in the West. So thank you.
Thank you, Oscar. And the gentleman here, please.
My name is Hashim Ahmed. I'm nuclear medicine and molecular imaging physicist. I've been kind of involved in many strategic plans in Sudan during the interim period. And what I've been seeing right now, I mean, from my point of view, I think, I mean, there is huge obstacles to do anything regarding to improve the health care during the war right now, for many reasons, corruptions, and it's a lot of things if you need to do that. So we need to be more innovative and more kind of creative in how can we provide service in the low scale level to many of those who are being caught up in this bloody war. So, I mean, I think the way forward is we have to see what the emergency community doing in the ground in Sudan right now, because what they're doing is amazing work and is very kind of courageous work, and they need to be involved in any sort of like mechanism of providing aids or medical aids, services, whatever it is. I mean, right now we're just looking into primary care health service as we've seen a lot of kind of outbreak. I mean, dengue fever, we see in cholera, so we, even in Port Sudan, where is the government, I mean, the government is based. So, I mean, because, I mean, I'm more concerned about cancer patients in Sudan right now, as we have right now only 2 venues providing some sort of like, I mean, basic or palliative care, not exactly curative care. So when we look into the infrastructure of the cancer service, Sudan is completely damaged. And my concern is part of these centers, which constitute many very high-tech machine involving radiation. And all this is, I'm sure it's been dismantled. And that's one of the issue people they should think of. And I think the International Atomic Energy, it has to be involved in this in order to kind of, because I mean, there is a lot of incidents happen in the past in South America. People, they, I mean, dismantle radiotherapy, cobalt machine. They took the source to the villages and everybody touched it. He has radiation sickness and so on and so on and so on. So this is an issue as well. I mean, if we want to protect people, as she said, I mean, if the healthcare is part of protection, but I believe it's kind of part of human rights for everybody. This human rights basics, I mean, as many wrote about it, I mean, in Haiti and all these sort of things. We've seen this kind of in Haiti and a lot of places. So we have to take lessons from these areas and trying to implement the basics. I mean, using telemedicine, using all sort of like technology, chat, GTB, all this we can use it in order to enhance, at least for time being, the healthcare for monies. Thank you.
Thank you, Hashim. A 5th question from the lady in front of me, please.
Thank you very much to the guest speaker and all the audience. I've got a quick question about during the crisis. So my name is Marwa Jibril. I am a GP, a Sudanese doctor, Sudanese British doctor. During the crisis, we see a lot of funding from donors is directed to vertical programs, which lead to fragmentation. We see a lot of workforce from the public health system that is, drained to work on these programs, leading to weakening health system. So what strategies can be implemented to make sure that whatever funding that comes is strengthening the already weak health system rather than adding to weaken the health system? Especially there is an issue, of course, of mistrust between the government and all these NGOs. There is a challenge, challenges in governance and capacity building and so on and so forth. So I would like really to hear from you on that aspect. Thank you.
Thank you very much, Marwa. Well, I'll pause the questions from the audience there and pass it back to the panel. I'll add in a couple of words. Deconfliction, thinking about the targeting of health infrastructure, and your words, Ibrahim, about medical neutrality, and a question for Nahid and Majdi also about how easy is it to advise the large international aid organizations? Any reflections on that? I will pass to the speakers. Ibrahim, would you like to respond first to any questions or comments that you have picked up on, and then proceed from that? Ibrahim.
Okay, I would like to respond about the issue of that to increase the awareness about medical neutrality is very important. This should be one of the takeaways from this meeting, because till now there is still ongoing conflict and still ongoing attacks on the health facilities and on the health personnel. So it should be one of the priorities, protection. And also, you should be advocates for the only thing we have to do is to stop the war. This is the main thing. Because as the war continues, the more victims, more destruction going on. So we are not talking about this. We should talk about stopping the war. And we have to be advocates, especially institutions like the London School of Economics, London School of Tropical Medicine, other international organizations should press hard on the governments to help in stopping this war. Thank you.
Thank you, Ibrahim. Nahid, would you like to respond to any of the questions?
Yeah, quickly, I would address the issue of how to advise the international humanitarian relief. But first, I think we all need to put a little bit of our thoughts about the war and how to stop, because without stopping the war, nothing will work. Everything is just a Band-Aid until we stop the war. And then we'll start answering the question, what's the best way to rebuild? But for now, we need to stop the war. And the biggest issue of not stopping the war, there is a question actually online, is what is stopping it from happening or from more action to stop it? Well, it's very simple. If the United Arab Emirates will stop supporting the rapid support forces, the war will stop very soon, very quickly. Now, I don't mean that the army, the Sudanese army is innocent, or we would actually, I'm not supportive of either party, they're both criminals. But if the international community really cares about human rights, international law, they would actually do something about the UAE interference and the others. It's not just the EU. Of course, we know there is also Russia, and at some extent it was Egypt and others. But the role of the UAE is huge. And the only reason it's not happening is because the West does not dare say anything to the UAE. The interest of the West with the United Arab Emirates is far beyond the millions that are suffering in Sudan. And that's a reality. We have to speak it out loud. It's in everywhere. It's in the articles in The Guardian, in the New York Times. It's not that it's a secret. It's just nobody's willing to do anything about it because of their own interest in the West. Now, back to the humanitarian, which is only a Band-Aid anyway. As I said, I've also mentioned that the only thing I am trying to press, everybody's important. The people with renal failure are important. The people with cancer are important. The dengue fever and all the infectious diseases and the chronic disease are important. But women's health gets ignored. And there are solutions. There is a lot of projects. People know exactly what to do, but they don't do it. Why? Because women's bodies are considered dispensable. So for me, I'm not saying the other issues are not important. I'm just saying for the issues that I work for, please, women are the silent sufferers, not only because they take care of their homes and their children, but even in their bodies. We need to actually shed light on that, and the solutions are known, they're not hidden. I don't even need to tell them, just ask UNFPA or whoever the big organizations that deal with reproductive health. Thank you.
Thank you, Nahed. There were heads nodding in here in agreement. Majdi, would you like to respond to any of the comments and questions?
I know so many great questions and points raised. And I think just to echo the point that has been made overarching all of this, the best health intervention that can be deployed in Sudan at the moment is peace. Just stop the war. And then that unlocks all the other things that we're discussing today around improving the health system, addressing vertical programs and issues around specific disease areas. So I'll let Eva sort of speak to how kind of perhaps as health workers and public health people, we can contribute in some way to making the case to whoever it needs to be told that this war needs to end. I think there was a comment raised about the experience in Argin, and thank you so much for sharing that. And sorry to hear that experience that shared by so many. And I think the one thing we haven't perhaps talked about too much is refugees or displaced people within Sudan, and then also the Sudanese that are outside Sudan as well, and the health challenges that they're facing, whether it's in Egypt having to pay extortionate fees for visas, or whether that's in Saudi, or whether that's even here in the UK. The treatment of Sudanese refugees is deplorable. And I think that's somewhere where perhaps, as physicians, as healthcare workers dealing with people in the community here and in Egypt and other countries, we can play a role in highlighting that more. So many other sort of great points. Dr. Baraka as well, I think everything that you said in terms of, the ultimate goal sort of peace, ending this health and humanitarian crisis being most important. And I think in terms of vertical programming, and for folks in the room who may sort of not have heard that term, it's just sort of the way that we structure health programs. Do you invest in a hospital, or do you say, I'm going to use this money to treat a particular disease? And, for the long-term durability of health, going broad, investing in health systems is the most important thing. But Sudan is even impacted more than that. There are some 19 million, I think, children who are out of school at the moment. Basically every child in Sudan is not in education at the moment. And we know that education and health are so closely tied. In Sudan, in Halfa, we have unfortunately seen cases of children blind from vitamin A deficiency. That's something you read in the textbooks, you don't see in real life. So the overlap of education and health and all the other things that we're talking about here ultimately come down to ending the war. I'll end there.
Thank you, Majdi. Eva.
Thank you. And vitamin A comes from food, nutrition, right? Health, education, nutrition. So that whole spectrum is something that we need to address. And I agree with you. I think on strengthening health systems, the corner of any health system is primary healthcare and community care. So you're absolutely doing the right thing. Building hospitals is, they're going to get reduced to rubble unless we have compliance with international humanitarian law, which means that those infrastructure won't be bombed and so on. There are quite a few comments. I'll try and sort of reference a line to each. You mentioned in regards to human rights and bringing in aid and the sort of implementation of aid and all this cross-border, cross-line that we talk about. Let's be clear, plenty of aid gets into Sudan. A lot of it is military aid. There's plenty of aid going in, yeah? That Adre border crossing, that border 100,000 sins are crossing every day, and yet there is bartering at the highest level for 2 trucks to come in. Go figure. Aid is a particular mechanism in the world. It operates a certain way. Life-saving doesn't appear to be the #1 objective anymore. If it was once, that's fair enough, but I think the international humanitarian system needs to ask itself some questions, not just in Sudan, but looking at other crises in the region and further afield. The international humanitarian system has a lot of thinking and a lot of homework to do, but that's my opinion. When it comes to aid coming in the traditional sense, there's Saudi aid, there's Emirati aid, but one phrase that we've started banding around is humanitarian gaslighting. Oh, have some guns, kill some people, here's some aid. We have to be careful of that. So just, the aid washing is something that is also a big feature, because a lot of these geopolitical actors are very media savvy, they're very reputation conscious, they don't want damage to their brand, to their PR, and so there is, aid can be co-opted as a, sort of a plaster to kind of, wash away their sins. Absolutely, to the, the position of the US, the UK, the EU, and others. Our country here is friends with a lot of the actors who are fueling this conflict. And so when it comes to the what can we do, what I've spent the past 1.5 years of my life doing is talking to Whitehall, talking to MPs, talking to FCDO and others, because that is where these friendships are made and policies are made. And that is where the advocacy should be. It should be on the streets, it should be online, but it should also be holding, to account those who are our government. And I think that applies to particular countries. And I appreciate that civil society doesn't look the same way in the region, and that Sudanese and other allies who live in the countries around Sudan don't have the same recourse, because civic space is tiny, it's oppressed, it's dangerous. So I think those of us who don't suffer the same issues yet, because God knows there are, let's say there's a lot of backtracking in civic space in the US and the UK. And so we need to watch for that, and in the meantime, use what we can. So ceasefire, if ceasefire is a way to bringing peace and ending the war, which is a separate step, political processes, mediation, etc. Those are 2 separate steps. They don't necessarily happen one after the other, but they are 2 separate steps. If those are day 1 and day 2, let's say, day 0 is protection. The parties to the conflict have signed a declaration. May 2023, it was a commitment to protect civilians. Having them actually trying to adhere to that, imploring them, asking them, mandating them through a resolution, for example, to comply with that agreement is a step towards having watchful eyes where they don't want them, to having documentation, to having telecommunications, to letting the air back in Sudan, to letting the information out of Sudan. And that is why the political processes are important, but also the multilateral, the bilateral, everything that can be thrown at this conflict should not just be ceasefire. Ceasefire is being held hostage. Nobody's coming to the table on ceasefire. We've got to get creative. And multilateral fora, the UN Security Council, are not the only place. There are other mechanisms. So we have to explore all of them. And we have to get literate fast, because as advocates, we have to go with the moving and changing sphere. And it is not easy for medics. It is not easy for health people who do not spend our time studying international, humanitarian law and so on. So there is a lot that is on our shoulders. And I implore people to take what they can on, being mindful that this could be for the long haul, being mindful that people have lives, being mindful of burnout and rest and respite and all of those things. But from my position, it is the only moral thing to do. I'll leave it at that.
Thank you, Eva. There's a little bit of momentum still in questions that have come online, and maybe 1 or 2 in the audience would like to ask a further question. So I'll just read, in summary, some of the online questions. Amal El Amin asks, what are the key barriers to preventing sustained international attention to the conflict in Sudan? Rihab Abdel Mussen asks, if the war were to stop tomorrow, what are the priorities for reconstruction? And Ellen Grunbaum, complimenting Nahid on your remarks, your presentation. She asks, she would be interested to hear more ideas on how to help women and girls vis-a-vis supplies, material supplies. And several others in the audience also thank. There's one, Eris Williams Reed asks, what roles do you think public health research funders, as opposed to humanitarian organizations, could be playing now and after the war ends? And Phyllis Ferguson thanks Nahid for her presentation as well. Questions in the room, please? Any to add? The gentleman here, please, if you'd like to introduce yourself and ask your question concisely. Yes.
I'm Abdurrahman Mohammed. I'm a retired, I know I look very young, but I'm retired general surgeon and emergency physician. Well, we all agreed that the war has to stop for anything to be done as something substantial. We live in a very cruel world. If you don't help yourself, very few people will help you. I think whatever we need to do it in our capacity. We don't talk big, and we know that it's not going to be done if no help is coming. I asked Dr. Mehdi. First of all, I say thank you. You're doing a very good job there. I hope they are keeping records and stats and everything so that it would be like a good experience for the next war, God forbid. And if your experience could be replicated, if you can actually advise, because you have a lot of experience, advise other people to do this in places where there is no conflict, where there's no war. And I think because most of the people from the war zone, if you like, actually gone around Sudan to places like Halfa and other places which are overwhelmed because there is a lot of people there. Thank you.
Thank you. The lady behind there, please.
I just have a quick question. First of all, thank you so much. It was a really insightful discussion. My name is Lina Bidri, and I just wanted to ask, not to go back into history so much, but also kind of looking back, what are kind of the structures and the implications of having a healthcare system specifically under 30 years of dictatorship and corruption that maybe led to this stage or also influenced what's happening now? Kind of just asking about the precedents maybe that were set for how healthcare has been dealt with in Sudan more widely. Thank you.
Thank you, Lina. And any last question from the audience? Otherwise, I will pass back to the panel. And if you'd like to make brief responses, and this can be your closing remarks. And Nahid, to you first then.
I just want to respond to this last question about the 30 years of a corrupt government that employed people based on their loyalty to the Islamist state as opposed to their actual merit, not on merit or skills. I think the biggest issue is the neglect of the public health programs in Sudan by far. I mean, that it's quite scandalous how much for 30 years public health has been relegated to the least important. The second is the privatization of health in Sudan. The 30 years have changed a system for what it's worth. Obviously, it could not be the NHS, but it was conceived with the idea that it would replicate the NHS, which is tax-based access to everybody, which, as we know, that's not easy to do in a low-income country. But still, the idea was access to health should be for everybody equally. And for 30 years, they have privatized the health system. And actually, also turned it into tertiary health. I think we all know that we all need to work on primary health and prevention, but they turned it into building hospitals, even in all the states, and also turning it into a private system where the government actually takes money to provide health as well as the independent private system. I think that's the vulnerability that this last question was about.
Thank you. Ibrahim, would you like to respond to anything and make any closing remark?
Yes, I would like just to comment that there is an ongoing initiative is in our capacity. What we can do is to help as Sudanese experts. There are two initiatives. One of them is Sudan Healing, led by Dr. Omar Suleiman in Cairo. Is working on an initiative to support the health system during and after the war. And also there is the Eastern Mediterranean Public Health Network is also working on an initiative, now coming up with projects that supporting the health sector. So this is the capacity of what we can do now. And also we need to work as advocates for these international health organizations. And also funding for research is very important, especially we need to see what's the impact of this war on the epidemiological trends going on. And also we need to investigate about the resilience of the Sudanese community during this war. It's really very interesting that a lot of ongoing that people are supporting each other and become more resilient now for a war going more than 18 months. Thank you.
Thank you, Ibrahim. Majdi?
Yeah, sure. So I think Lina and Dr. Abdurrahman's question was related in some way. I think, and as Eva said earlier, health is political. And the nature of Sudan's health system is that it's been extremely concentrated in Khartoum, and along with that, so has been funding from within Sudan in terms of out-of-pocket payments for healthcare, as well as funding from outside. And in a way, what this war has revealed is the effects of that over the last 30 years, where the peripheries and towns and cities and outside of Khartoum have been completely neglected and not ready for the conflict and the impact that it's had. And so, what we're seeing now, in some ways, is an adjustment to that, with people moving out to these other places like Port Sudan or Halfa. And with that, health systems are having to cope and adapt. And so, if we're trying to sort of look at the glass half full of this, perhaps, hopefully, what this may open up in the future is a more decentralized health system that is based more in the community. And when it comes to public health funding agencies, what can they do to stimulate that? They can actually invest in research today in terms of understanding what is the best model of care that communities can deploy today. We don't have to wait till the war is finished to actually do research. And if anything, I think it's the right thing to do, because still we have to understand whether or not what we're doing is working. And so, yeah, our team are doing regular assessments in the community to look at the effects of the program. But I think funding for research is really critical and ties to what Dr. Nahid said as well around ethics, and not just looking at health as an extractive thing, but that's something we can, not only provide to that individual that we're treating, but creating public goods, creating knowledge that can improve the health system over time. So, yeah, I'll pause. There's so many other points that I could talk on, but I'll pause there.
Thank you, Majdi. Eva, to you.
Thank you. I think when it comes to public health research, it's a matter of interest. Research is political. There's a shock. And what is researched is also a very particular type of decision and a particular appetite, and particular interest. And sometimes it's in line with, foreign policy when it's happening abroad, or some global health security matter, for example. I bet you if the latest novel virus broke out in Sudan, suddenly public health will be all over us. And it would look very different. So sometimes these things are a bit value-ridden. That is a part of the problem. You know, I've worked in hospitals where, you know, sort of surgical wound care was completely revolutionized by using honey, for example, as a structure to, you know, to heal, especially deep abscess wounds and so on. And that was introduced by Sudanese doctors. There is so much innovation in Sudan. And unfortunately, war right now is also creating innovation. There is a lot that the research world could learn, as well as providing funds, you know, actually opening up opportunities for displaced researchers, displaced, you know, health practitioners, people who are trying to support that, trying to take an interest, but don't have the funding to do that. And it's a really cutthroat world, you know, the kind of public health research world. So I think if donors, if research institutes could take an interest and actually liberate some of that funding, that would be great. When it comes to the healthcare system under dictatorship and so on, absolutely, everything that Dr. Nahid said in terms of the kind of mafia-style operation of everything that the state ran, right? The WASTA system, or yeah, I'm going to come to you later. But, you know, when you have a country that enjoys 1% of its national budget to both health and education, what does that tell you? When you have 80% of that GDP going to the military was not interested in civilians and Sudanese before the war. Let's not have that conversation now. I'm personally not interested. When it comes to a very centralized health system, this war, unlike many others, started with a capital hit. That is a very big deal in war terms. It stops everything. And for a very centralized system like in Sudan, that really had a catastrophic effect on payments, on knowledge, on know-how, on, you know, logistics, on cold chain, on everything. So that is a big part of it. But the neglect of public...
The health system in Sudan is being decentralized by Mahmoud Ahmed. When Ibrahim came, he was trying to kind of push the whole primary system to the rural area, and very kind of...
And there are initiatives by individuals trying to do X, Y, and Z, absolutely, and especially during the transition period and so on. But we're talking about 30 years, right? 30 years where it was a very different picture, and that sowed the seeds. Privatization wasn't just because Sudanese doctors are, you know, evil people who want lots of money from poor patients. The international community has something to answer for here. Structural adjustment. Yeah, anybody from the development world, that was a big part. You want loans, you need to take money out, you not to have a welfare state, no NHS for you, Sudan. That is a 30-year-old story. So let's not just take, you know, the Sudanese architecture into it. Let's also look at the international architecture that mandated that in Sudan, that in fact invested in projects to see how this neoliberal economies could work. That is a big part of the story of privatization in Sudan. And let's not forget who props up Sudanese, you know, health services, welfare services, education, you know, religious, whatever. It is Sudanese civil society. Sudanese civil society in Sudan, displaced, in the near abroad, and in the diaspora, have been at work for 30 years. That is who has been propping up Sudan for 30 years, despite the regime. But when it comes to war, who gets to go to the table? Who gets to go to the hotels around Europe, including today? Who is there being a power broker when what power have they exercised except their own pocket? The power is with the people, the power is with the network, but that is not who the international community wants to do business with. And again is the complicity. So what we have to do is open that up. We have to let the air in and say, you need to talk to the people who are sleeves rolled up, knees in the mud, doing the work. And some of them are the doctors and healthcare practitioners that Dr. Majdi's work is supporting, but all of the other humanitarian responders, those who've become overnight humanitarian responders, those who are mortgaging their cars and their homes and everything to their hand in order to respond, in order to run a soup kitchen. Those are the heroes, those are the power, and that is not who's at the table, and that is what needs to change.
Thank you very much, Eva. We should draw a close to the seminar at this point. We've run on considerably longer to nearly 7:30. So I would like to close by asking you all to put your hands together to thank our 4 speakers. And our thanks should also go to Nadine El-Manasfi, the events coordinator at the Middle East Centre, for putting together this event. And my thanks to you, the audience who are here in person, many of you who have travelled from across London and perhaps elsewhere to the event, including 2 of our speakers. And our thanks again to our 2 speakers online, Nahid and Ibrahim.